So good evening everybody. Let us start with today's topic. So we are on day 6 today. So our topic to complete today is the vasculitis syndromes. Right. So we have gone through the entire chapter of rheumatology. We have gone through the entire rheumatology. I hope we are all clear till now. What is autoimmune disease? What is the clinical approach? We studied lupus, arthritis disease. So today we want to go ahead with the vasculitis syndromes. Right. So let's get started with a quick recap. So as we go along, the recap gets shorter and shorter. So we can go little faster today. Right. So today's topic is the vasculitis syndrome. We have started on day 2 and 3. We have done the lupus. Okay. So we have done 4 and 5 arthritis syndromes. So today, day 7, we want to start with the vasculitis group of disease. Right. So vasculitis group of disease is the one if the characteristic feature purpuric skin rash is present, then it strongly favors the diagnosis of vasculitis. Please remember everybody that purpuric skin rash is a characteristic feature, need not be present in every case. When it is present, it becomes easy to suspect the disease and we can start for the ANCA antibody testing. We can start with the ANCA antibody testing, that is anti-neutrophilic cytoplasmic antibody testing. Right. So on the recall, we know that vasculitis syndrome needs to be divided into 3 broad groups. Vasculitis syndromes need to be presented with the classified further based on the predominant size of the vessel affected. Based on the predominant size of the vessel affected, we want to begin with. And so the vasculitis syndrome, as we read in medicine, are divided into large vessel vasculitis, medium vessel vasculitis, and the small vessel vasculitis. So this is the one we have done before. Okay, so this is where we are. So let us start with the diseases today. So among the vasculitis syndrome, we want to do the classification. In modern medicine, we are using the classification based on size of the vessel affected. But there is an older classification also that we want to begin with. Older classification we want to begin with, that is based on the pathology involved. So vasculitis syndrome are also classified. We have got based on the pathology involved. It is divided into 3 groups. Please write down. All of you have to take down this table. You have to start writing this table. So based on the pathology involved, it is divided into 3 groups. Based on the pathology involved, it is divided into 3 groups. The 3 groups, one is antibody, that is ANCA mediated. Antibody, that is ANCA mediated. There is immune complex mediated disease. Immune complex mediated disease. And we have got the T cell mediated vasculitis. Please remember the T cell mediated vasculitis are also known as granulomatous vasculitis. Please remember T cells. Whenever T cell activation is present, we know, example tuberculosis infection, there is granuloma formation in the affected tissue. That is why T cell mediated vasculitis are also called as granulomatous vasculitis. They are called as the granulomatous vasculitis, we can say. So based on the pathology involved, we are going to divide the vasculitis syndrome into 3 groups. One, antibody mediated, that is ANCA mediated. Number 2, immune complex mediated. And number 3, T cell mediated vasculitis, also called granulomatous vasculitis. So let us see which are the diseases under each of these heading. Which are the diseases under each of this heading? Let us write from the first one. Under ANCA mediated vasculitis, there are 3 syndromes. Under ANCA mediated vasculitis, there are 3 syndromes. This is our first slide. This is the first slide for today. Classification of vasculitis syndrome based on pathology involved. We have divided them into 3 groups. So under antibody mediated, number 1 is the Wegener's granulomatosis. Number 1 is the Wegener's granulomatosis. We have got Church-Strauss syndrome. So please write the short form also for future reference today. So Wegener's granulomatosis. There is number 2, Church-Strauss syndrome, and there is the disease microscopic polyangiitis. There is the disease microscopic polyangiitis is present. So number 1, under ANCA mediated vasculitis, we have got Wegener's granulomatosis, Church-Strauss syndrome, and we have got microscopic polyangiitis. We want to know. Under immune complex mediated disease, under immune complex mediated disease, we have got 2 important syndromes to discuss. Under immune complex mediated disease, we have 2 important syndromes to discuss. One syndrome is the PAN, polyarteritis nodosa. One syndrome is PAN, polyarteritis nodosa, and number 2 is the HSP. HSP is your Henoch-Schwann purpura. Please remember, the new name for HSP is the anaphylactoid purpura. New name for HSP is the anaphylactoid purpura. Okay, so HSP, Henoch-Schwann purpura, the new name is the anaphylactoid purpura that we are to discuss today. So today we are going to discuss the individual vasculitis syndrome. We are starting the class with the classification. Then we will go into individual syndromes. Okay, so coming to the last column, T cell mediated vasculitis. Last column, T cell mediated vasculitis. We have again 4 syndromes. Write it carefully. We have giant cell arteritis. We have got giant cell arteritis, Takayasu's arteritis, Wegener's granulomatosis, and Church-Strauss syndrome. Under T cell mediated vasculitis, we have got 4 syndromes: giant cell arteritis, Takayasu's arteritis, Wegener's granulomatosis, and the Church-Strauss syndrome. So this also is an approved classification for vasculitis syndrome, though we do not use it commonly in clinical practice. So it is mainly important for MCQ, because MCQ can also ask statement regarding underlying pathology, can ask the pathology regarding the underlying pathology. So this slide will help us understand what is the pathology of different vasculitis syndrome. The ones which are not there are idiopathic in nature. Okay, so that is the correct point we want to see here, that why are we not using this classification? Why are we not using this classification? Because of the problem pointed out by Urmish Patel. The problem pointed out by Urmish Patel. What we have seen, that Patel Bhai has said Wegener's granulomatosis and Church-Strauss syndrome are present on both sides. They are present under 2 groups because they can have dual mechanism. They can have dual mechanism. Yes, and that is why it is not preferred. That means it is not exclusive. Very good. So the correct answer, even though this classification is correct, but we do not use this in practice because it is not exclusive. Because some of the diseases can have more than one pathology. Can have more than one pathology, and that is why we don't prefer this classification much. Right? So come to the modern one. Come to the current one. Come on. So come to the current classification. The current classification that we have. Current classification, vasculitis based on size of the vessel predominantly affected. Based on the size of the vessel predominantly involved also, we are dividing vasculitis syndrome into 3 groups. Okay, so what I want you to do, same way. So first classification table you made, that was pathology. Second classification, now you can write short forms because all syndromes have already come. So one, we have got large vessel vasculitis. We have got large vessel vasculitis, under which we are going to study two syndromes. Under which we are going to study two syndromes. One, giant cell arteritis, GCA, and other one, Takayasu's arteritis. So we are going to start. This is the second page of today's class. First page was the classification based on pathology. Now we are dealing with classification based on size of the vessel affected. Again, I am telling you, reading it slowly, listen, understand and write please. Okay, it's not a rapid fire contest. So large vessel, we have got giant cell arteritis, GCA, and Takayasu's arteritis. Under the heading medium vessel vasculitis, under the heading medium vessel vasculitis, we are going to study the one syndrome, polyarteritis nodosa. Even though I have written down two, why I am saying we are going to study one syndrome? Because Kawasaki's disease is affecting pediatric population. So it is covered in the pediatric class. We will not overlap and create confusion. Okay, keep only one source in the class. So polyarteritis nodosa we are going to discuss. Medium vessel, another example is Kawasaki's disease, which you will be discussing under the pediatric class. Come to other side, the small vessel vasculitis. The small vessel vasculitis have to be further subdivided based on the ANCA status. So continue the table to next page. Continue the table please. So one, under large vessel vasculitis, we want to study two topics, giant cell arteritis, Takayasu. Under medium vessel, we want to study one topic, PAN. And under small vessel disease, you have to continue this classification table based on ANCA status. So this table I am going to continue further. Based on ANCA status, you continue the classification into two. So the small vessel vasculitis are broadly divided into two. Those which are ANCA positive, those which are ANCA negative. So we divide the small vessel vasculitis into two. Small vessel vasculitis into two. One which is ANCA positive and other which is ANCA negative. Under the heading ANCA positive, we can further subclassify based on whether C ANCA is present or P ANCA is present. So within the ANCA, there are two subtypes. Within the ANCA, there are two subtypes, the C ANCA and the P ANCA, based on which we are going to subclassify the disorders. So ANCA positive, if it is C ANCA positive, if it is C ANCA positive, you will note here please, C ANCA is an old terminology. C ANCA is an old terminology. The new name is the anti-PR3. The new name is the anti-PR3, that is antibody against proteinase 3. Antibody against proteinase 3. So in modern medicine, if you send a blood sample to the laboratory to do C ANCA, laboratory will say we don't have such test. Because all of you know laboratories are all computerized and the technician sitting will search for C ANCA, but C ANCA does not exist now. Now the correct name you must send the sample for anti-PR3. Send the sample for anti-PR3, that is proteinase 3, and the disease is Wegener's granulomatosis. So in Wegener's granulomatosis, majority of the patients are C ANCA positive. in Wegener's granulomatosis, majority patients are C ANCA positive. But if P ANCA is positive, you must consider two differentials. If the P ANCA is positive, we must consider two differential diagnoses. So P ANCA, the new name is anti-MPO. P ANCA, the new name is the anti-MPO, that is myeloperoxidase, antibody against myeloperoxidase. And under that heading, we have got two differentials. One is the Church-Strauss syndrome, other is the MPA. MPA is your microscopic polyangiitis. MPA we have already written under pathology, microscopic polyangiitis we want to discuss. Please remember that the P ANCA can also be positive in minority of Wegener's patient. So what we have to do? We have to understand that rheumatology is all about matching both clinical symptom with the corresponding antibody, and that is how you reach the final diagnosis. So this is under, yes, color coding is always there, right? So this is under the small vessel vasculitis. This is under the small vessel vasculitis. So small vessel vasculitis we have subclassified into two based on whether they are ANCA positive or ANCA negative. If they are ANCA positive, we want to discuss Wegener's. If they are C ANCA positive, and if there are P ANCA positive, we must consider Church-Strauss syndrome and microscopic polyangiitis. We have written MPA in the pathology list now. Microscopic polyangiitis, we have written it. Please refer to the previous slide. Under the side, there is ANCA negative. If it is ANCA negative, we want to look at anaphylactoid purpura. We want to discuss anaphylactoid purpura, that is HSP. Anaphylactoid purpura, that is HSP, and we want to finish today's class with discussion on Behçet's disease. We want to finish today's class with discussion on Behçet's disease. So again, let me tell you, under vasculitis syndromes, there are many small syndromes also. Okay, like Cogan's syndrome, somebody mentioned. Cogan's syndrome is mainly covered under ophthal because their main manifestation is interstitial keratitis. So what happens is that everybody focus that there are many autoimmune disease, but we are focusing on the important topics frequently asked in the exam. So let us make it simple here. So what we have got here, ANCA positive, ANCA negative vasculitis syndrome. So again I am telling you which are the diseases we want to discuss today. So under large vessel we want to discuss giant cell arteritis, Takayasu 2. Under medium vessel we want to discuss PAN. We want to discuss three syndromes under ANCA positive, Wegener's, Church-Strauss, MPA. Under ANCA negative we want to discuss anaphylactoid purpura, and we want to finish today's session with Behçet's disease. We want to finish with the Behçet's disease. We want to look at them, right? So this is our classification that we want to do, right? So let's continue further. So now we want to start with the individual disorders. Come on. So now that, see what is the thing. I hope you are all able to understand that you know how it is. Whenever as medical students, please listen carefully, as medical students, we are always tuned to prepare ourselves for the university based examination. So what happens invariably is that we look at the previous year's question bank and we study only those topics which are frequently asked. Okay, so that is a planned approach. It is a planned approach. But many times in the rush to read the topic, what we forget to do, we forget to read the basics about the topic. we directly read the topic. Giant cell arteritis is a famous disease. Temporal arteritis is a common short answer question. We might have studied this, but today we have started with our classification first. So every time remember, when you want to read a particular topic, don't read only that topic. First, at least understand to which group of disease the topic belongs to. So that, because clinical suspicion is a very approach wise method. So directly you don't jump to the diagnosis GCA hoga. First we suspect कि autoimmune disease हो. When patient comes to clinic, you directly don't think GCA होगा. We think autoimmune disease हो. Within the autoimmune disease, we try to differentiate. What we do? Try to differentiate. Whether it is lupus, whether it is arthritis, whether it is vasculitis, whether it is the myositis, or it is overlap. And then we are going to start understanding the individual disease. That's how we want to go for that. Right. So GCA already covered in neurology class. Very good. I'm very happy. So you can answer that. Okay. So you can answer the questions. So Joglekar can answer questions. Maulish Reddy all answer questions. Great. So let us start with that. Okay. So kaisa hoga? So giant cell arteritis, old name is the temporal arteritis. You can open those notes if you want, and you can add any point if it is different. Okay, chalo. So start with the first point. So giant cell arteritis is the most common form of systemic vasculitis in adults. Okay, it is the most common form of systemic vasculitis in adults. Most common form of systemic vasculitis in adults. Okay, I will go very fast, but I want answers with me. Okay, so let us do that one by one. Giant cell arteritis is also known as Horton disease. Giant cell arteritis is also known as Horton disease. It's okay. Whatever we have covered, there is nothing wrong to revise, because this remains a very important topic that we want to discuss. So our method, let us fill the pro forma. After definition comes epidemiology. After definition comes epidemiology. So giant cell arteritis is a disease of elderly female. It is a disease of elderly female. So more than 50 years, we call this the post-menopausal age group. Post-menopausal age group, we are going to have, we can suspect giant cell arteritis. So Harrison mentions in volume 1, there is a chapter on headache. And in that headache chapter, it is written that when an elderly, that is post-menopausal female, comes with headache, please consider diagnosis of GC. So it is that important to us. Okay, it is that important to us. So epidemiology, more than 50 years, female dominant disease. Female dominant disease. Okay. So don't bother. Organ specific vasculitis, you will study under the organ system concern. Okay. So today it is not that class, no. So why you are going into that mode when we can conclude what is there first? We'll mix up. When you get the full picture, you will learn that. But right now we focus on GC. So giant cell arteritis, elderly female. The cause is idiopathic. The cause is idiopathic, unknown. But what is pathology? So cause may be idiopathic, but what is our pathology? The pathology, as we discussed today only, first slide of today's class, first slide. What is the pathology? The pathology, it is a T cell mediated granulomatous vasculitis. It is a T cell, one line by one line I am reading for you to write, understand and proceed. Based on, just recall, with the classification table, you will be able to answer many questions. You have to just connect the two. So it is a T cell mediated granulomatous vasculitis, which shows Transmural. Come to the next sentence. Come to the next sentence. Transmural inflammation of the affected vessels. So transmural means throughout. Transmural. Transmural inflammation of the affected arteries can occur. Can occur with patchy infiltration by lymphocyte. With patchy infiltration by lymphocyte, macrophages, and multinucleated giant cells. Multinucleated giant cells. And because of the presence of giant cell in the pathology, the name has been given giant cell arteritis. On the first day of rheumatology introduction, I told you that all the names which have reference to geography, example, familial Mediterranean fever, all the names which have reference to scientist, example, Sjogren's syndrome, Retter's syndrome, all those diseases which have reference to only common symptom like this one, temporal arteritis, are no longer preferred because the names do not describe the disease properly. So all the new nomenclature is given based on pathology, and it helps the medical student, helps the medical practitioner understand the disease better. We should not give random names. Temporal arteritis क्यों बोलते थे? Because it is the most common artery involved. Yes, but does not mean it is the only artery involved. All of you remember the analogy to scleroderma. Scleroderma बोलने से the patient starts feeling चमड़ी की बीमारी है, only skin problem, which is not true. Same way, if you tell temporal arteritis, people feel only headache hai, but it is not just temporal. Okay, it can affect all many other branches of aorta also, and that is why the new names are based on the pathology. So I am giving you one by one. So giant cell arteritis is a disease commonly affecting postmenopausal female. The cause is unknown, but the pathology, T cell mediated granulomatous vasculitis with transmural inflammation and having infiltration of multinucleated giant cells. Okay, so I also believe that these old names should be eradicated, but MCQ वाले इसी से तो मजा लेते हैं ना. Most of our professors enjoy torturing us by giving old names, उनके जमाने के नाम, है ना, उससे अपने को बर्बाद करते. तो ये हमको एटीट्यूड नहीं चाहिए, बट फिर भी करना पड़ता है. आगे चले. ओके, सो म्यूरल हाइपरप्लेजिया. सो व्हाट हैपेंस when the artery is inflamed? Why should the symptom come? When the artery is inflamed, why the symptom is there? Because the hyperplasia can narrow arterial lumen and resulting in ischemia, leading to the various manifestations. So all the areas, all the structures which are supplied by the arteries which are affected will develop ischemia, which leads to the various manifestations of the disease. Okay, so I'm going slow. This is an important chapter. Even if you have covered it before, nothing wrong. It is still remains an important chapter, right? Let us take it further. So giant cell arteritis, after pathology comes clinical feature. Okay, I want all of you to get used to this simple proforma in medicine. I am sure that most of you have got used to it, and I hope that you are able to use that for every system of medicine. Whenever you study a topic, textbook में हर topic के 6-10 पेज है. Every topic has many pages. But after reading those, I want you to learn to condense the information. into the headings that we have prepared. Once we do that, we will be able to get the correct points about the disease. So coming to that, transmural means all layers of the vessel, throughout the layers of the vessel, intima, media, everything. Transmural, throughout the layers of the artery. All the layers of the artery is affected, right? So giant cell arteritis, what is the clinical feature? What is the clinical feature? So giant cell arteritis, remember the dictum. Giant cell arteritis predominantly affects branches of carotid artery. Predominantly affects branches of carotid artery, though it can also affect aorta, subclavian, ilia, and the vertebral artery. So what we have to do? Giant cell arteritis predominantly affects branches of carotid artery, but it can also affect other large artery. Remember the word, it is a large vessel vasculitis. Large vessel vasculitis. So remember the point, 1 to 2% of the cases have aortoarteritis, have got aortoarteritis, can be there, and which can predispose to the dissection, and on examination, what finding we can get? Radiofemoral delay. We can get the finding radiofemoral delay. Okay, I will show the slide. Okay, let us finish this clinical feature slide. Then I will show you the pathology last line. Please leave one line and continue. So one point, it affects the branches of carotid artery, and but it can also affect aorta. Aortic involvement is rare. You can see here 1 to 2% only have aortoarteritis, which can lead to dissection and narrowing of the lumen, which can cause the sign radiofemoral delay. Radiofemoral delay, these signs we will discuss under cardiovascular system. We will be discussing under cardiovascular system. We will be going to see. Next point, the manifestation. So what are the manifestations due to? So clinical feature can be due to the artery affected. Clinical feature can be used to the artery affected, as well as the pathology of the disease. Okay, so this is a common dictum. This is a common dictum in medicine. Throughout medicine, the common dictum is that there is the disease, the manifestations will be due to the site, in this case artery affected, and due to the pathology of the disease. Okay, so let me tell you what we have got here. So what we have got here, common example for you to understand. When the patient of pneumonia comes to you, where is the site of infection? Lung. That's why they get cough. But problem, pathology is infective. That's why they get fever. So the symptoms are always due to either the site and the pathology. Site or the pathology. That's what we want to discuss here. So please note that the symptoms due to pathology are likely to be common but non-specific, because individual disease specific is area. As I told you, gave you the example of pneumonia presenting with cough and fever. Fever is a non-specific symptom, though common, it is non-specific. Presence of cough tells you lung is the site of infection. So pathology are likely to be common symptoms but non-specific for the diagnosis. Radiofemoral delay, I told you already, we will be discussing under cardiovascular class. We are not going to do CVS here. First we will become rheumatologist. Cardiologist bhi main hi banane wala hu. Arvind sir has done most of the job. He has already taken ECG for you. Remaining cardiology, I will take it for you. So radiofemoral delay, all these signs, we will discuss this along with cardiology. So presently focus on giant cell arteritis. Focus on the giant cell arteritis, right? So continue further. So what is our knowledge? So to understand what are the symptoms, we want to know anatomy. To know the symptoms, I told you, depends upon artery affected. So you want to know which areas are supplied by branches of carotid artery. Which arteries areas are supplied by the external carotid artery, are created by the external carotid artery and internal carotid artery, we want to see, right? So branches supply. Let's make a table, please. External carotid artery, internal carotid artery. Yes, you must write this. Anna, there is no question रे, है ना, what to write. You must write ना. Information आ रहा है. वो भी एकदम simplified chart में. You must write only. That is simple for us to do, right? So branches supply. Let us see. So what is this? Number one, external carotid artery. Anna, I want you to remember like this. Please look at me here. Okay. So here we have got our superficial temporal artery. Superficial temporal artery supplies the skull. Okay. Superficial temporal artery supplies the skull. It also supplies branches of external carotid. Branches of external carotid also supply extraocular muscle. Okay, extraocular muscle. It also supplies muscles of the jaw. They also supply muscles of the jaw. And finally, it supplies the sensory root of the trigeminal nerve. It supplies sensory root of the trigeminal nerve. Okay. So external carotid artery, the branches, superficial temporal supplies the area of the skull. The branches of external carotid also supply extraocular muscle. They also supply the muscles of the jaw. And it also supplies sensory root of trigeminal nerve, which carries the sensation from half of the face. Okay. So please remember. So kaisa hai? When you have the knowledge of anatomy, you can predict the symptoms in medicine, because symptoms depend upon the area affected. Accordingly, you can match the symptoms. So same order mein we will write the symptoms also, so you can understand the reason behind the symptom better. On the other side, internal carotid artery. First branch of internal carotid artery is the ophthalmic artery. First branch of internal carotid artery is the ophthalmic artery. First branch of internal carotid artery is the ophthalmic artery. What is ophthalmic artery? It is an example of end artery. Please remember, in anatomy, correct, first branch of ICA is the ophthalmic artery. It is a end artery. End artery means artery with no collaterals. That means it is an artery with no collaterals. It is artery with no collateral mean end artery. Ophthalmic artery. The ophthalmic artery gives rise to the posterior ciliary arteries. Ophthalmic artery gives rise to the posterior ciliary arteries, which when affected, please note this point, which when affected causes anterior optic neuropathy. That is anterior ischemic optic neuropathy. So it is a little different. Even though it is the posterior ciliary artery which are affected, posterior ciliary arteries supply the optic head, which is responsible for anterior optic neuropathy. is responsible for anterior optic neuropathy, which causes abrupt, painless, and often permanent blindness. So if this artery is affected, you can get abrupt, painless, and often permanent blindness. That is abrupt, painless, and often permanent blindness. So important है. So clinical feature depends upon awareness of your anatomy. So once you have taken this down, we can continue to the clinical manifestations of giant cell arteritis. Clinical manifestations of the giant cell arteritis. So write it down, please. So giant cell arteritis, what are the manifestation? Excellent. So actually this week has been quite an integrated learning because you got immunology from micro class, you are learning a bit of ophthal, and hopefully we can all connect these points here. So giant cell artery manifestations. Okay, so make the column here, giant cell arteritis, giant cell arteritis. Okay, so in giant cell arteritis, the blindness is abrupt, it is painless and sudden. Okay, we will again verify. Okay, we will again verify. पेनफुल दिया है तो पेनफुल लिखना है ना, बट एक बार वापस देख लेते हैं है ना, डोंट वरी, पैनिक मत करो. सो कैरोटिड आर्टरी इन्वॉल्वमेंट. ओके, कैरोटिड आर्टरी इन्वॉल्वमेंट के नीचे लिखिए, अंडर कैरोटिड आर्टरी इन्वॉल्वमेंट लेट अस राइट डाउन, external carotid artery branches are most commonly affected. Okay, external carotid artery branches are most commonly affected, Okay, so what is there? Most common branch within the branches of external carotid artery, most common is the superficial temporal artery. Most common is the superficial temporal artery. So this superficial temporal artery involvement is the one which causes unilateral or bilateral throbbing headache. Because of the involvement of superficial temporal artery, you get the most common symptom. The most common symptom is unilateral or bilateral throbbing headache. You get unilateral or bilateral throbbing headache, which worsens on supine position. Please remember, this is very important. Because whenever you get a throbbing headache in a female, the first differential is migraine. Whenever you get a throbbing headache in a female patient, the first differential is migraine. But we all know migraine attacks relieve after sleep. So we all have heard, maybe some of you have experienced a migraine. What we do when we get migraine? We shut the lights and we take medicine, painkiller, go to sleep. So after rest, migraine relieves. But opposite occurs in GCA. What occurs in GCA? There is going to be worsening on supine position. The reason is unknown. But the character of the headache is this. Okay. Why it worsens is unknown. But in giant cell arteritis, it worsens on supine position. And there is also scalp tenderness. That is the most common symptom of GCA. So most common symptom is because of the most common artery affected. That is why the old name was temporal arteritis. But we know along with that there can also be the defect in supply to extraocular muscle. There can be problem in extraocular muscle, which can lead to diplopia. So defect in the extraocular muscle can lead to diplopia. There can be jaw claudication pain. That means when you use the muscles of the jaw, mastication, when you use the muscles of the jaw, the blood supply becomes inadequate and patient complains of pain. So when the patient is chewing, masticating for long, the patient can experience pain because there can be deficiency in the blood supply. And there can also be paresthesia over the face. There can be paresthesia over the face. Okay. So paresthesia over the face, where it is over the fifth cranial nerve distribution. It is seen in the trigeminal cranial nerve distribution. Trigeminal cranial nerve distribution you are going to get, because we have seen in anatomy that what does branch of external carotid supply? Supplies the superficial temporal, supplies extraocular muscle, muscles of the jaw, and sensory root of the trigeminal nerve can be occurred. Along with this symptom, 30% of cases, along with this symptom, sensory symptom, paresthesia is a sensory symptom. No, I told you, sensory root of trigeminal is supplied. If supply is not there, you get paresthesia. Okay, come to other side. Other side, in 30% cases, in 30% of the cases, you get the symptom polymyalgia rheumatica. In 30% of the cases, you get the symptom polymyalgia rheumatica. Very important symptom. In 30% you get the symptom polymyalgia rheumatica. So question number 1, what is this polymyalgia rheumatica? What is this polymyalgia rheumatica? So polymyalgia rheumatica is not a disease. Polymyalgia rheumatica is a symptom complex. Polymyalgia rheumatica is a symptom complex. So what is a symptom complex? Consisting of the myalgia, low grade fever, anorexia and weight loss for a minimum duration of 3 months. It is a symptom complex. It is a symptom complex. Symptom complex. Okay, which is consisting of the myalgia, low grade fever, anorexia and weight loss for more than equal to 3 months duration. Okay, so please look at it carefully. Please look at this carefully. When the patient complains of fever, again I am telling you a clinical approach. Listen to this. When patient complains of fever, the common cause can be infection, especially in our country. First differential is always infection. Second differential we saw autoimmune disease. Third differential can be neoplasm also. So when a patient complains of fever, they are likely to be suffering from either infection, autoimmune disease or neoplasm. So how can we fine tune the diagnosis? So what we thought, we took the extra point of duration. So duration is additional point. So symptom complex. Fever alone can have many causes. But fever for more than 3 months. In 3 months, it is a thought. Okay, it is a thought that in 3 months, if infection is left untreated, if cancer is left untreated, patient can deteriorate and may even die. So if more than 3 months are there and patient is reasonably stable, then you must consider rheumatology disease. Then you must consider rheumatology disease, that is autoimmune disease. So when a fever is present in more than 3 months, you must consider the patient as having the symptom complex polymyalgia rheumatica. Polymyalgia rheumatica, which can be seen in other rheumatology disease also. Can be seen in other rheumatology disease also. But rheumatology class में आज हम क्यों पढ़ रहे? Because most common rheumatology disease associated with the symptom complex is GCA. Most common rheumatology disease associated with this symptom complex is the giant cell arteritis. That's what we have. So polymyalgia rheumatica is a non-specific symptom. So let us look at this carefully. Yes, so we look at this carefully that our patient is an elderly female who comes to you with a headache which looks like migraine. This headache is often associated with non-specific symptom polymyalgia rheumatica. That is when you must suspect the disease. Right? That is when you suspect the disease. But the danger, as you pointed out, headache and fever do not cause death. The dreaded complication of the disease is the irreversible blindness which occurs due to internal carotid artery involvement. Because that is the dangerous complication in the disease. Okay, that's what we are worried about. The other dangerous complication, write down, other dangerous complications are stroke, which can cause death in 20% cases, myocardial infarction, which can cause death in 2% of the cases. Okay, it can have 2% of the cases. So the patient can have the symptom in 30% of the patients. That's what we have written. Okay, so what we have understood here, that when the patient has having GCA, so elderly female having headache, constitutional symptom, think of GCA. Because if you don't treat early, they can develop dangerous complications like blindness, stroke, myocardial infarction. They can develop blindness, stroke, and myocardial infarction can occur. So look at this simple point: suspect, screen, and confirm. So what we have discussed till now is the clinical suspicion. So till now we have learned how to clinically suspect GCA. All we have to do is to screen and confirm. Yes, we will go fast. So when to suspect? The disease? When an elderly patient, headache which mimics migraine in an elderly patient, especially female, you suspect the disease. So to suspect the disease, you must suspect when the patient has got headache which mimics migraine in elderly, especially female gender. Once you have a patient in your clinic who has suspected the disease, what we have got? You check for ESR. The screening test is the ESR. Myocardial infarction occurs in 2% of the patients. Okay, ESR is more than 60 is strongly suggestive. So ESR more than 60 is strongly suggestive of the disease. So you can do a screening test using ESR. But confirmatory remains, okay, temporal artery biopsy. Temporal artery biopsy is the gold standard. So again, controversial topic, but this is what is our consensus. Ideal size of the biopsy. So when you take a biopsy specimen, you must tell the surgeon to take minimum, ideally 3 to 5 centimeter. You must try to take 3 to 5 centimeter size of the vessel. 3 to 3 centimeter you must say. But minimum size should be more than equal to 2 centimeter. But minimum size should be more than equal to 2 centimeter. More than equal to 2 centimeter. Right? So how it is? We must make sure, because if the size is less than 2 centimeter, then the report is considered inconclusive. Report is considered inconclusive. We must know. Right? So we take a temporal artery biopsy is the gold standard test. Gold standard test to confirm the disease. But please remember, the sensitivity is the problem. When I say gold standard, when I say gold standard, the test is specific. But sensitivity of the biopsy is not much. Sensitivity is not much. It is 30 to 44% only. Okay. So please see, this is the rheumatology class. This is the rheumatology topic. This is the update in latest textbook. So follow these figures. Okay. This is what we want to follow. So sensitivity is less. So we can also look at the non-invasive test. There is always non-invasive test. You can go for MRI, you can go for ultrasound to look for the vessel involvement. You can do. So every time when the patient has a symptom, ESR is high, you must do the biopsy. But it is not necessary that every time biopsy will confirm the disease. So we can also look at other non-invasive tests to look for detect artery involvement, though it is non-specific. So many times the error in the biopsy is to take a small length. That is the error which can make the report inconclusive. Then you might have to repeat the biopsy. So the diagnosis is done, come to the treatment. So steroids remain mainstay of treatment. Okay. So steroids remain the mainstay of treatment. So steroids you start the patient. But what to do? First give steroids like SLE. You give in SLE full dose 1 to 2 milligram per kg body weight. You have to give 6 to 8 week course, offers remission. And then you taper the steroid over 6 months in majority. So in giant cell arteritis, you are going to start the patient. On steroids. After 6 to 8 weeks, once the symptoms have resolved, you will start tapering the steroid and you can discontinue the steroid in 6 months in majority of the patient. Please remember, empirical steroid without biopsy report, when to give. Empirical steroid without biopsy report is only indicated in cases with ocular symptoms with impending blindness. So whenever that MCQ question, if the patient has only headache, polymyalgia rheumatica, you will not start steroid without confirmation. But if the patient has come with blurred or diminution of vision, you will start the steroid along with taking the biopsy. So this is indicated only when the cases have got ocular symptom with impending blindness. Ocular symptoms with the impending blindness can be done. So what can we conclude? Concluding giant cell arteritis. Prognosis with early diagnosis and treatment is good. Prognosis with early diagnosis and treatment is good, but delay can lead to the problem. But delay in the treatment is leading to the problem. So we want to start the patient in early. Steroids you want to give to prevent blindness. Okay, you want to start the patient on steroids. That is how you want to consider management of GC. So we have concluded the first large vessel vasculitis. We have completed first giant cell arteritis. First large vessel topic we have completed. Okay, moving on to the second. The second topic is the Takayasu's arteritis. The second topic under large vessel vasculitis. Okay. Now we can increase the speed. You have got an example. One disease. Okay. Similar proforma. You want to fill in the next disease. Similar proforma. You want to fill in the next disease. Right. So Takayasu's arteritis. Aortic arch syndrome. Takayasu's disease is now called as aortic arch syndrome. It is called as the aortic arch syndrome. Takayasu's arteries is also known as the pulseless disease. This is old, also known as pulseless disease. Known as the pulseless disease. Right? So in cases with severe subclavian stenosis, upper limb pulse may be absent. So previously, when the diagnosis of the disease used to be delayed, many patients used to develop severe subclavian stenosis. In severe subclavian stenosis, there used to be upper limb pulse used to become feeble and it may also disappear. And that is why it was called as pulseless disease. But as I told you, we are not going to consider that because it is a rare and late feature of the disease. So the best name is the aortic arch syndrome. The best name is the aortic arch syndrome. We want to remember that. Best is the aortic arch syndrome. What is the epidemiology? The Takayasu's arteritis affects young female. Takayasu's affects the young female. Bracket there is only aortic arch syndrome. In the bracket there is aortic arch syndrome. That's all. Okay. Aortic arch syndrome. So epidemiology, the disease affects young female most commonly. Most commonly it affects young female, 10 to 20 years, female dominant disease. Etiology remains idiopathic. Okay. Are we able to write with me? Etiology is idiopathic. The etiology is idiopathic. Okay. The pathology, please recall from our first slide of the day. Pathology is a T cell mediated granulomatous vasculitis. Recall the pathology from first slide of today. That is T cell mediated granulomatous vasculitis. Right? So a young female can present with Takayasu's disease. Okay? Takayasu's disease. Right? So what are the clinical features here? What are the clinical features we want to know? Clinical feature, again remember, based on the artery affected. So Takayasu's artery can affect all direct branches of aorta. That's why the name aortic arch syndrome. Okay. So the Takayasu's arteries can affect all direct branches of aorta. That is why the new name aortic arch syndrome. The new name aortic arch syndrome we have got. Hence it is called as aortic arch syndrome. So write down the manifestation. Here also aorta is affected. That is why it is got the radiofemoral delay may be present in this disease also. It can be radiofemoral delay can be present also. And we know this point that the manifestations depends mainly on the artery affected. Okay, manifestation depend upon the artery affected. We have already learned that point. So please remember, anatomy, Takayasus can affect all direct branches of aorta. One by one, we will enumerate the artery and corresponding symptom. We will enumerate the artery and the corresponding symptom. Write the order now. Write the order. Most common artery affected is the subclavian. Most common artery affected is the subclavian, followed by the carotid artery, followed by the vertebral artery, celiac artery, renal artery, and the least common is the coronary artery. So most commonly it affects the subclavian, followed by the carotid, followed by the vertebral, the celiac, the renal, and the coronary artery, which is least commonly affected. Okay, we'll write it down step by step. Again, now that we have dealt with these same points, we are going little fast. So manifestation depends upon the artery affected. So we have written from most common artery affected to least common artery affected. Most common is subclavian, least common is the coronary. Most common is subclavian, least common is the coronary. That's what we have written, right? So these are the arteries affected. Let us write the corresponding manifestation. Let us write down the corresponding manifestation, right? So demand for the again previous slide. Okay, previous slide में कुछ नहीं है, but still सब लोग मांग रहे हैं, है ना? So please quickly see. We have written name, epidemiology, etiology, and pathology. That's all. Okay. So this is our pathology basic idea. Okay. Then we have got the clinical feature. I have put it for you based on the artery involved. We are going to write. Again, everybody is going on the same question. Radio femoral delay. मैंने बोला कार्डियोलॉजिस्ट बनेंगे तब सीखना, है ना? We'll go for cardiologist that time, not now. Now, manifestation. Manifestation, what is there? Manifestation depends upon artery involved. So we'll make a point here. So what is this artery involved and the manifestation? Okay, one by one we will write. So subclavian artery most commonly affected. Subclavian artery is most commonly affected, and subclavian supplies the upper limb. So patient can have upper limb claudication and unequal pulse. Upper limb claudication and unequal pulse can be present. Carotid artery, vertebral artery can present as recurrent transient ischemic attack and young stroke. Carotid and vertebral supply the nervous system. So it can cause recurrent transient ischemic attack or young stroke. The celiac artery can cause chronic mesenteric insufficiency. The renal artery stenosis can cause hypertension. And the coronary artery can present as young myocardial infarction. And that is why what we have to remember, when to suspect Takayasu's disease. We will suspect Takayasu's disease when the patient is a case of young myocardial infarction, when the patient is having young hypertension, or the patient is a case of young stroke. Please remember, these are the clinical clues. To the diagnosis. So when a young girl comes with hypertension, young girl comes with stroke or with infarction, you must consider the diagnosis of the Takayasu's arteritis. You must consider. So again, same point, we have to suspect, screen and confirm. We have to suspect, screen and confirm. We have to confirm the diagnosis. So as I told you, when to suspect the disease. I have given the clinical clue. When to suspect the diagnosis. When a young stroke, MI, hypertension is present with upper limb claudication pain. Okay, so upper limb claudication pain is present. You will suspect Takayasu's disease. Then on examination, you can have unequal upper limb pulsation. You can have upper limb pulsation. Initially, when the stenosis is mild to moderate, the pulse will become feeble. When it becomes severe, pulse will become absent. Okay, so initially the pulse will be feeble on the affected side. Pulse will be feeble on the affected side, and eventually they will lead to absent radial pulse. Eventually it will lead to absent radial pulse. Okay, that is the examination clue that we have. But the gold standard test is the CT aortography. Gold standard test is the CT aortography. So CT aortography is the gold standard test in front of you. Gold standard test in front of you. Okay, I'll show you the last slide. Okay, so let's wait till this. So we have got gold standard CT aortography. It shows multi-vessel stenosis. So you can see here, this is the aorta. We can see there is narrowing here, stenosis here. So multi-vessel stenosis. Multi-vessel stenosis. Okay, multi-vessel stenosis on the CT aortography can be the gold standard for diagnosis. Okay, so manifestation हमने लिखा under corresponding vessel. Coronary block होने से patient will get young myocardial infarction. Renal artery block होने से patient gets renal artery stenosis, which can manifest as a young hypertension. That's what we have got. So CT is gold standard. Gold standard matlab confirmatory. That is confirmatory of the disease. Pulmonary artery can be rarely involved. Yes, can be rarely involved in 10% of the cases. Okay, so this is what we want to see. On examination, on examination, OE matlab on examination hai. Okay, again coming to the treatment. So what is the treatment here? Investigation of choice is CT aortography. Investigation of the choice. Okay, so you can see there is a stenosis here. This is the arch of aorta. Arch of aorta is here. Carotid stenosis is here. Here also there is a stenosis. Here also there is a stenosis. So even though the symptom is heavy, okay, so you can see this wedge shaped appearance is there, where the pointer is wedge shaped appearance. These are the stenotic areas. Here also you can see the flow has become less. Wedge shaped are the stenosis that you can see. So even though the patient has come with stroke, patient aortography will show other arteries are also affected. Only carotid is gone, we can say atherosclerosis, but multi-vessel involvement you can see. So there is no screening. Screening is only by clinical examination. There is only clinical examination. CT aortography is the confirmatory test. Okay. So what are the screening? Management remains same. management remains the same. So steroids remain again the mainstay of treatment. Steroids remain, sorry, this slide has come back. So this is the old slide. Just we will stop here. This much only we want to know. Steroids are the mainstay of treatment. Steroids are mainstay of the treatment. Okay, I'll go slow, don't worry. है ना, स्लाइड डुप्लीकेट हो गया, इसको करेक्ट करते हैं ना. प्रोग्नोसिस, right. So steroids remain the mainstay of treatment and majority require lifelong treatment. Majority require lifelong immunosuppression. Lifelong immunosuppression is required. And you also have to do, also there has to be palliative stenting has to be done. Palliative stenting has to be done for the pre-existing stenosis. For the pre-existing stenosis, palliative stenting has to be done. Palliative stenting has to be done. And so, what are the problems? The patient young age is affected. There is unpredictable course of the disease. There is unpredictable course of the disease. So the young female can develop stroke, can develop MI anytime. Okay, so young age is affected. There is unpredictable course of the disease. There is high cost of treatment, and there is adverse drug reaction of immunosuppression. Adverse drug reaction of immunosuppression. Hence the prognosis remains poor. Hence the prognosis remains poor. Okay, so I am typing it for you here directly. There was a little error in the slide, so we got it here. That management, you are having the steroids are the mainstay of treatment. Steroids are the mainstay of treatment. But unlike our GCA, unlike the GCA, majority require lifelong immunosuppression. Majority require lifelong immunosuppression. Also, palliative stenting has to be done for the pre-existing stenosis. Palliative stenting can occur for the pre-existing stenosis. Okay, so young age is affected. There is unpredictable course of the disease and high cost of treatment and adverse drug reaction of immunosuppression make the prognosis poor. Make the prognosis poor. Okay, so it is not anything of inherited. The cause is idiopathic. Okay, cause is idiopathic. There is no inherited point here. Okay, so what we want to know, look at the status one by one. So first two large vessel, we have written first two large vessel cases here. Large vessel vasculitis we have described. So one large vessel vasculitis, one large vessel vasculitis. Okay, this we have completed. Okay, so again tell with me, giant cell arteritis. Come on, keep it here and tell me. Giant cell arteritis. Giant cell arteritis. Patient is having the elderly female presenting with headache, other symptoms, and treatment is steroid, but early treatment, good prognosis. But in Takayasu's disease, it affects young female. Aorta, multi-vessel are affected, leading to young stroke. Young myocardial infarction can lead to young hypertension, making the prognosis poor. making the prognosis poor. So these both are T cell mediated vasculitis. There is no role of ANCA. Correct. These are T cell mediated vasculitis. Okay. We have got the T cell mediated vasculitis. We have confirmed here. Let us go forward. So beyond the large vessel, now we have to move on to the polyarteritis nodosa. We have to go for polyarteritis nodosa. We want to continue. Polyarteritis nodosa. We want to continue. Right? So first, polyarteritis nodosa or PAN. So polyarteritis nodosa. Okay. Polyarteritis nodosa. PAN we want to discuss. PAN we want to discuss. Right? So let us start with epidemiology. Come on. Now we will go fast. Same proforma fast. I am giving you direct notes. I am giving direct notes. Let's go fast. Right? Polyarteritis nodosa. Epidemiology affects middle-aged males, 30 to 50 years, male more than female. 30 to 50 years, 30 to 50 years, males more than females, males more than females. Etiology is idiopathic. Etiology is idiopathic. Etiology is idiopathic. Most commonly is the cause is idiopathic in 70% of the cases. So when the cause is idiopathic, we call it as the classical polyarteritis nodosa. Please remember, like Sicca syndrome, when the cause is idiopathic, that means PAN is the disease. That is why we call it classical PAN. But before you refer the patient to rheumatology, you must exclude chronic hepatitis B infection. You must exclude chronic hepatitis B infection. You must exclude chronic hepatitis B infection. Must be excluded. But important is the pathology. Important is the pathology. Recall from first slide. Recall from the first slide of the day. PAN is immune complex mediated vasculitis. PAN is a immune complex mediated vasculitis. Immune complex mediated vasculitis which causes fibrinoid necrosis. Which causes fibrinoid necrosis. That is why the new name. That is why the new name for PAN is the systemic necrotizing vasculitis. The new name for PAN is the systemic necrotizing vasculitis because immune complex disease causes fibrinoid necrosis where it affects the medium-sized vessels. It affects the medium-sized vessels where it affects right at the bifurcation. So PAN affects the medium-sized vessel right at the bifurcation. Right at the bifurcation. When the bifurcation of the artery is damaged, we all know artery contains blood under high pressure. If the junction of the vessel has become weak, it can predispose to microaneurysm formation. That is how damage to the vessel can lead to microaneurysm formation. So very simple pathology I am giving you. So polyarteritis nodosa is a disease of middle-aged males. Majority times the cause is idiopathic. But before you refer to rheumatology, you must exclude chronic hepatitis B infection. The pathology is the immune complex mediated disease which causes fibrinoid necrosis. I have color coded the names and the reason. Why the new name? New name here, systemic necrotizing vasculitis. Why the new name? Because of the pathology. It causes fibrinoid necrosis. Fibrinoid necrosis, where in the medium vessel, it is a medium vessel vasculitis, right at the bifurcation, which leads to microaneurysm formation. Leads to the microaneurysm formation can occur, which leads to the manifestations of the disease. Let us look at that. So clinical feature. Let us come to clinical feature. Clinical feature we have got here, most commonly arthralgia. Most commonly arthralgia. Why arthralgia? It is due to pathology. Please recall, pathology, immune complex mediated disease. Immune complex mediated diseases means what? Type 3 hypersensitivity, also called as serum sickness, where more commonly they get joint pain. Arthralgia is the most common symptom, but unfortunately non-specific. Come on, if we get a patient with joint pain, directly we cannot think of PAN. So as I told you with the GCA, the manifestation of the disease, common manifestation may be due to pathology also, but it is not helping in the diagnosis. The diagnosis comes based on the artery involved. Most common artery affected in PAN. Most common artery affected in PAN is the renal artery. Most common artery affected in PAN is the renal artery, because of which the patient develops complaints of hematuria. That is why the patient develops complaints of hematuria. But please remember, in this autoimmune disease, hematuria is not because of glomerulonephritis. Hematuria is secondary to microaneurysm rupture. In this patient of PAN, hematuria is secondary to microaneurysm rupture. It is secondary to the microaneurysm rupture. Microaneurysm rupture. Okay, microaneurysm ruptures leading to hematuria. What is important? It is the only autoimmune disease which causes hematuria without causing glomerulonephritis. Without causing glomerulonephritis. SLE can cause nephritis. Sicca can cause nephritis. Hematuria can occur in lupus disease also. Please remember, hematuria can occur in lupus disease also. But there, the mechanism of the symptom is different. So, if a middle-aged patient has arthralgia with hematuria, you must suspect PAN. Along with that, cutaneous manifestation can be there. Cutaneous manifestation can be there. Cutaneous manifestation can be in the form of Raynaud's phenomena. But the most specific skin manifestation in PAN is libido changes. Most specific skin manifestation in the PAN is libido changes. That is mottling in the skin. Libido, this term you will study in forensic medicine. Post-mortem mottling, libido changes. So if you get it in a live person, please think of PAN. When you get it in a live person, think of PAN. Okay, so that is what we have. So most specific cutaneous manifestation is the libido changes. है ना? GN is glomerulonephritis. है ना? मुश्किल हो गया. So what we have got here, cutaneous manifestation. Continue further here, CNS manifestation. Mononeuritis multiplex. Recall lupus disease. mononeuritis multiplex. Recall the lupus disease. Okay, so why I want to emphasize here is that polyarteritis nodosa is a vasculitis syndrome, but the presentation can look like lupus disease. The presentation can look like the lupus disease. Okay, presentation can look like lupus disease. So all of you, if you remember, in scleroderma we said patient can come with Raynaud's phenomena. Patient can come with hematuria due to renal involvement. Patient can also develop mononeuritis multiplex. Mononeuritis multiplex. And that is why the disease of Pan can look like lupus disease. Can look like the lupus disease. But what cannot occur in lupus is the gonadal artery involvement. So whatever I have written in red color, please remember color coding continues. Whatever is there in red color is specific to Pan. Whatever is in black can be also seen in lupus disease. Whatever is in black can also be seen in lupus disease. Okay, can be seen in the lupus disease. Okay, so we have written. So what is happening, that the integrated medicine, I told you the first day, you have to have the orientation of the past session. Otherwise, you will keep asking doubts which are irrelevant. Okay. So again, previous notes padke ana. Correct. I agree totally. Previous notes padke ana. Very good. Gonadal artery involvement. So gonadal artery involvement is a typical feature of Pan. Typical feature of Pan. So that can present with abdominal pain. That can present with abdominal pain. Okay, mononeuritis multiplex is the most common autoimmune disease associated with mononeuritis multiplex is Pan. Most common autoimmune disease associated with mononeuritis multiplex is Pan, that we have discussed when we discussed the point mononeuritis multiplex. Okay, abdominal pain can occur with gonadal artery involvement, and that can mimic torsion because the testicular artery or the ovarian artery can be involved, leading to severe pain. We can get patient of Pan can come with abdominal pain. Lung involvement 1 to 2% can come with bronchial artery involvement. 1 to 2% can come with the bronchial artery involvement we want to see. Okay, but please remember what is not affected is important, helps to differentiate from other disease. So in the MCQ, Pan is a very common question because the pathology is unique. Clinical features can mimic other lupus disease. So you have to read the question for the red color, that is specific manifestation of disease. And also pulmonary circulation is spared. Pulmonary artery does not get aneurysm. Pulmonary artery does not get aneurysm. And ANA, ANCA are negative. Because what is the pathology? Immune complex, not antibody mediated. Immune complex, not antibody mediated. So these tests help us differentiate the Pan from other disease. Help the patient of Pan to be differentiated from other disease. Right? So how to diagnose the disease? Renal angiography. Yes, the diagnosis can be done by two methods. If renal artery is the most common artery involved. Renal artery is the most common artery involved. And that is why renal angiography can be done. Renal angiography can be done. microaneurysm at the bifurcation is a gold standard. So if the renal angiography shows microaneurysm at the bifurcation, it is the gold standard. It is the gold standard. Or if renal artery is not involved, you can also go for biopsy of the affected organ. If the patient has renal artery is not involved, patient only has skin manifestation, patient only has neuropathy, you can go for biopsy of the affected organ. You can also go for the patient with the biopsy of affected organ. You want to check that, right? So what is there? Here in the renal angio in front of you, you can see microaneurysms present. Microaneurysms are present. Microaneurysms are present. Okay, right at the bifurcation. MA. Okay, there is the microaneurysm is present at the bifurcation. Is present at the bifurcation. Okay, so this is why after the diagnosis you start the patient on immunosuppression with good prognosis, favorable prognosis. The treatment is immunosuppression with favorable prognosis. Treatment is immunosuppression with favorable prognosis. We want to know, right? So this is the topic of PAN. So we come to the last level. So we completed medium vessel vasculitis also. So everybody, we did large vessel, medium vessel. Come to last part of the session. Last part of the session, ANCA positive, ANCA negative. We want to look the C ANCA, P ANCA, Wegener versus Church-Strauss. We want to look at HSP and finish our class today with Behçet's disease. So we have got 4 topics, rather 5 vasculitis syndrome to discuss. Gold standard, GS is gold standard. Okay, so here you want to give long-term treatment only. Long-term treatment is given, but outcome is favorable because mortality is low in PAN. Okay, so come to further. So ANCA positive, ANCA negative. We want to discuss these 5 syndromes. Okay, first let us start with the MPA. So when we talk about vasculitis syndrome, small vessel vasculitis syndrome, focus is on the differential diagnosis. When we talk of vasculitis syndrome, small vessel vasculitis, focus is on the differential diagnosis. Focus is on the differential diagnosis, right? So differential diagnosis, ANCA positive vasculitis, ANCA positive vasculitis. So what is the differential diagnosis for the ANCA positive vasculitis? What is the differential for ANCA positive vasculitis? Answer is Goodpasture syndrome. The differential diagnosis is Goodpasture syndrome. So ANCA positive vasculitis can mimic Goodpasture syndrome. How? We will see. Okay, so write little faster. Come on, point to point. Last small topics, point to point. So ANCA positive vasculitis can mimic Goodpasture syndrome. Can mimic Goodpasture syndrome. So Goodpasture syndrome is a classical pulmonary renal syndrome. Goodpasture is a classical pulmonary renal syndrome. Come on, very fast we have to write. Okay, very fast. GPS, Goodpasture syndrome, is called as classical pulmonary renal syndrome. Next point, Goodpasture has anti-GBM antibodies. It has got anti-glomerular basement membrane antibodies directed against the alpha 3 subunit of type 4 collagen. So Goodpasture syndrome is a differential diagnosis for ANCA positive vasculitis. It is the differential diagnosis for ANCA positive vasculitis. Goodpasture is the classical pulmonary renal syndrome where there are antibody against alpha 3 subunit of type 4 collagen, where there is antibody against alpha 3 subunit of type 4 collagen, which is present in alveolar and GBM, which is present in the alveolar basement membrane and the glomerular basement membrane. So alpha 3 subunit of type 4 collagen is present in two organs. It is present in the alveolar basement membrane and the glomerular basement membrane. Okay, leading to the two symptoms. What are the symptoms? Hemoptysis occurs due to alveolar hemorrhage and glomerulonephritis occurs due to GBM involvement. That is why the name pulmonary renal syndrome. That is why the name pulmonary renal syndrome. Hemoptysis occurs, glomerulonephritis occurs, and there is no other organ involvement in Goodpastures. There is no other organ involvement in Goodpasture syndrome. No other organ involvement in Goodpasture syndrome. Only two organs are affected. Hence it is called as the classical pulmonary renal syndrome. It is called as the classical pulmonary renal syndrome. But the minute other organ involvement is present, but in this patient, if other organ involvement is present, note the line, note the connection. If other organ involvement is present, that is the patient has skin rash, uveitis, etc. Patient has got skin rash, uveitis, etc. What you must suspect? Consider ANCA positive vasculitis syndrome. So along with the pulmonary renal involvement, if other organ, multi-system, other organ is also affected, then you must consider not as Goodpasture, but consider diagnosis of ANCA positive vasculitis. Yes, ANCA positive vasculitis. So ANCA positive vasculitis. Okay. So the cause of hemoptysis is alveolar hemorrhage. The glomerulonephritis leads to hematuria. Glomerulonephritis leads to hematuria. So this, when there is other organ involvement present, you consider ANCA positive vasculitis. So please remember, what is your ANCA positive vasculitis? Three we have written. We have written Wegener's, Church-Strauss syndrome, microscopic polyangiitis. Recall, ANCA positive, we have written three. We have written Wegener's, Church-Strauss and microscopic polyangiitis. Microscopic polyangiitis. So let's finish that first. So let us finish microscopic polyangiitis. Come on, faster. Just we are writing point to point, faster. Microscopic polyangiitis, MPA, was previously part of PAN. Microscopic polyangiitis was previously part of PAN. Was previously part of PAN. So it shares why they were considered same disease. They were considered same disease because it shares the epidemiology, the etiology, the clinical feature, the treatment and prognosis with PAN. So microscopic polyangiitis shares the epidemiology. Can you recall please with me? What is epidemiology of PAN? 30 to 50 year male dominant. What is etiology of PAN? Idiopathic. clinical feature we studied, treatment and prognosis. Treatment is immunosuppression, prognosis is favorable. So microscopic polyangiitis is similar to PAN because it shares the epidemiology, the etiology, the clinical feature, treatment and prognosis. So in the MCQ, how to differentiate? In the MCQ, how to differentiate that whether it is PAN or it is MPA. That is why we have got the except points. Which are the point which favor the diagnosis of MPA? We are going to write. So first point in MPA, lung involvement is more common. If you recall, again, if you recall, in the PAN, we have written 1 to 2% only have got bronchial artery involvement. So in PAN, lung involvement is rare. But in MPA, lung involvement is more common. Relative, it is more common. Number 2, renal involvement in the form of glomerulonephritis can occur. Renal involvement in the form of glomerulonephritis can occur. Number 3, purpuric skin rash may be present. Purpuric skin rash may be present. Okay, so we are comparing it with PAN because microscopic polyangiitis looks like PAN, but MPA, lung involvement is more common. Glomerulonephritis can occur. We have written classical PAN does not cause GN. Number 3, purpuric skin rash may be present. Number 3, purpuric skin rash may be present. Unlike PAN, PAN is a medium vessel vasculitis. Compare, PAN is a medium vessel vasculitis. MPA is a small vessel vasculitis. And the pathology is ANCA mediated vasculitis. The pathology is ANCA mediated vasculitis. Okay. Another DD Nere, Manu, where are you lost? Anna? That is not fair. Where are you lost? Anna, I am telling it 100 times. What is it, DD? Anna, I am telling you 100 times that we are discussing small vessel vasculitis. Small vessel vasculitis divided into ANCA positive. ANCA positive में 3 topic है. Out of that 3 topic, they can be differential for good posture. उसमें से I started with first microscopic polyangiitis because it is a part of PAN जो हमने अभी पढ़ा है, which we have studied just now. Come on, wake up. Huh? So we have written the differentiating points here. Differentiating points, how it is different. All other points are common. Don't have to repeat again. Don't have to repeat again. Chalo, moving forward. Anna, nahi to we have to do. Let us go fast. Chalo, let us come to the next topic here. So next topic, what is the differential? ANCA positive hai. Come on, ANCA positive. So other two, what are ANCA positive? When the patient comes with hemoptysis and glomerulonephritis. Patient comes with hemoptysis and glomerulonephritis. Glomerulonephritis, it is called pulmonary renal syndrome. When the patient comes with hemoptysis and glomerulonephritis, it is called as pulmonary renal syndrome, जो हमने पढ़ा. Okay, so हमने पढ़ा कि क्या है वो, that it is the classical is good posture. But if it is ANCA positive with other organ involvement, the differentials are Wegener's granulomatosis and Church-Strauss syndrome. The differential diagnosis are Wegener's and Church-Strauss syndrome. Microscopic polyangiitis को हमने खत्म कर दिया. What remains among the ANCA positive? Wegener versus Church-Strauss syndrome, that we want to compare. Wegener versus Church-Strauss syndrome you want to compare. So what is the point? Epidemiology. Continue further. Epidemiology. Continue further. So both Wegener and Church-Strauss. Wegener and Church-Strauss is important है ना. लास्ट स्लाइड तुम लोग छोड़ोगे नहीं मेरे को है ना. चलो है ना. चलिए. सो अगेन आई एम टेलिंग लिसन एंड राइट. उसीलिए बोल रहा हूं लिसन एंड राइट. फटाफट होना चाहिए है ना. दिस इज नाउ द एंड ऑफ रूमेटोलॉजी यार. कम ऑन. दिस इज ऑलमोस्ट द एंड ऑफ रूमेटोलॉजी. द सेम कंसेप्ट्स आर देयर. ओके. सेम कंसेप्ट्स आर देयर. गुड पास्चर का स्लाइड आई विल पुट इट ऑन एफबी. राइट. Oh God, come on, come on, come on, come on. Right, chalo. Right, whatever is left, please ask in the end, really. Yeah, epidemiology is common. Pathology, we have written. Pathology, we have written. Okay, pathology, we have written. So, ANCA mediated. There are two pathologies. First slide today. Two pathologies are possible. It can be antibody mediated also. It can be T cell mediated also. Dual pathology, as Patel Bhai pointed out. Yeah, Wegener and Church-Strauss. Remember, dual pathology is possible. Dual pathology is possible. Okay, antibody mediated. Aage, clinical feature. Come to clinical feature. Clinical feature, lung involvement, pulmonary renal syndrome. Lung involvement, pulmonary renal syndrome. Continue the table. Continue the table. Right. So lung involvement in Wegener is in the form of multiple cavities with abscess. It is in the form of multiple cavities with abscess. And the adult onset asthma is in the Church-Strauss syndrome. So Wegener is in red, Church-Strauss is in purple. Compare and let us continue the table. So both of them can have lung involvement, though manifestation is different. Lung involvement is there, but manifestation is different. Right? Lung involvement is there, but the presenting manifestation is different. Kidney involvement can occur. Kidney involvement can occur in the form of nephritic syndrome. Kidney involvement can occur in the form of nephritic syndrome. Okay, I will go slow. So we are discussing differentials of pulmonary renal syndrome. Pulmonary renal syndrome में classical है good pasture syndrome. But good pasture with other organ involvement. Think of ANCA positive vasculitis. उसमें से Wegener and Church-Strauss look more similar to the good pasture. That's what we are comparing now. That's what we are comparing now. So kidney involvement can be in the form of nephritic syndrome. Both of them can present as nephritic syndrome. Ana? Nephritic syndrome. 70% risk of RPGN. 70% risk of RPGN is present in Wegener. 30% risk of RPGN is present in Church-Strauss. Is present in Church-Strauss. Is present in Church-Strauss. So pulmonary renal syndrome, matlab lung and kidney manifestation is there in both, and that is why they mimic good pasture. That is why they look like good pasture syndrome. They look like good pasture. But what is different? Other organ involvement. So upper respiratory tract, है ना, जो पढ़ा नहीं उसको छोड़ो, मैं समझाऊंगा. अडल्ट ऑनसेट अस्थमा के नीचे लिखा है पल्मनरी ईएसनोफिलिक सिंड्रोम. Church-Strauss is also belongs to the group of pulmonary eosinophilia syndrome. Church-Strauss also belongs to the group of pulmonary eosinophilia syndrome. So you will cover Church-Strauss as a differential for asthma also. Church-Strauss is a differential for asthma also. Pulmonary eosinophilia syndrome is a group of disease who come with lung involvement and eosinophilia in the blood, that is called as pulmonary eosinophilia syndrome. One of them is Church-Strauss syndrome. One of them is the Church-Strauss syndrome. Coming back here, down. Upper respiratory tract involvement. Upper respiratory tract involvement can occur. Most common manifestation of vaginal. Most common manifestation of vaginal is chronic sinusitis. Most common manifestation is the chronic sinusitis. They can also develop serous otitis media. They can also develop serous otitis media and subglottic stenosis. Serous otitis media and subglottic stenosis. Okay, 70% come with allergic rhinitis. They come with the allergic rhinitis. So, along with that, skin rash can also be present in both. Skin rash can also be present in both. But skin rash is present over the lower limb. Is present over the lower limb in vaginal. Skin rash present over the lower limb is vaginal. Generalized, think of Church-Strauss. Generalized, think of Church-Strauss. It is the ocular manifestation which helps differentiate between the two. It is the ocular manifestation which helps differentiate between the two. Which two? Wegener and Church-Strauss. Because in Church-Strauss syndrome, ocular manifestation never occurs. In Church-Strauss, ocular manifestation never occurs. In Wegener, if affected, most common ocular manifestation is panuveitis. Okay, what I have written, please note, ocular involvement is not common, but if affected, ocular involvement is not common, but if affected, the most common ocular involvement is panuveitis. The most common, the ocular involvement is the panuveitis. Can be panuveitis. We want to remember. Okay. So after this, what is the diagnosis? Diagnosis starts with the screening test. Diagnosis starts with the screening test. Most common antibody. Most common antibody. Most common antibody. 70% we have already discussed come with C ANCA. Wegener 70% are C ANCA positive, which are now called as anti-PR3, while 70% of Church-Strauss, 70% of Church-Strauss have got anti-MPO, will have anti-MPO positive. So what are they? Screening antibody. Vasculitis screening antibody is our ANCA. Screening antibody is the ANCA. So after, clinical suspicion should be there. Okay. So clinical manifestations in front of you. What you should do when the patient has, in a summary, when patient has hemoptysis, kidney failure, along with other organ involvement like upper respiratory tract, like skin rash, uveitis, think of vasculitis. Ocular manifestation present, it has to be vaginal because ocular does not occur in Church-Strauss. So you will consider the clinical suspicion of the disease. Once you suspect the disease, you start with the screening antibody. Right? Screening antibody. So screening means most common antibody present. Okay? Ocular manifestation in Church-Strauss is absent. That's the difference. Confirmatory is by biopsy. But in MCQ, you are asked drug of choice. We are asked the drug of choice. Drug of choice. Cyclophosphamide is the drug of choice for vaginers. Cyclophosphamide is the drug of choice for vaginers. And steroids are the drug of choice for Church-Strauss syndrome. Cyclophosphamide is the drug of choice for vaginers. Steroids are the drug of choice for the Church-Strauss syndrome. Right? So ANCA screening test. Yes, ANCA. These are ANCA only, no? Anti-PR3 is C-ANCA. Anti-MPO is P-ANCA. Screening antibody is ANCA positive. So the prognosis, final line. What is the prognosis? Unfavorable in vaginal because risk of renal failure is 70%. Risk of renal failure is 70%. Okay, and it is favorable in Church-Strauss because the risk of RPGN, renal failure, is only 30%. Risk of renal failure is only 30%. Right? So this is what we want to understand. Okay, so what is the point here? Goodpasture's syndrome is the classical pulmonary renal syndrome. But along with lung and kidney, if other site is affected, think of ANCA positive vasculitis. The closest mimic is vaginers, followed by Church-Strauss, because microscopic polyangiitis looks more like pan rather than Goodpasture. Microscopic polyangiitis looks more like pan than the Goodpasture. That's why we have arranged it in this pattern. So one of you had asked, is tuberculosis differential? Yes. Tuberculosis is a differential for everything, my boy. Remember, ये है ना pearls of medicine viva है. Tuberculosis can affect and present anyhow. So it is non-specific symptom. But you are right that it can be, vaginal can mimic tuberculosis. Correct. That is the correct points to be known. Okay. So what we are knowing here, this is our points. So last 2 points to be done. We will finish this. Of course, today we are going to finish vasculitis. Because only 2 pages. I want you to write only 2 pages. That too in this, like this table only. Very, very simple. So ANCA positive we have completed. Wegener, Church-Strauss we have completed. Now we have 2 topics to do. Henoch-Sloan purpura and Behçet's disease. Henoch-Sloan purpura and the Behçet's disease we have got here. Right? So come on, let's come to the next topic. So Henoch-Sloan purpura. So very simple, write down with me. I am directly giving you the notes. Just write down with me. Okay? Just go with the points. Last 2 topics for the day. ANCA negative vasculitis. Just go step by step. Okay? Same proforma. Henoch-Sloan purpura. 90% of the cases occur in children. 90% of HSP occur before 10 years of age. 90% occur before 10 years of age, and especially male dominant disease. male dominant disease. Anna, आज today you don't have micro class. Anna, I have also seen on the Facebook club, Mamta madam has said today no micro class. So 10 o'clock I don't think you have class. So we can continue. 20 minutes we will complete our topic. Right? So 90% of the patients are less than 10 years male dominant disease. That is called as classical HSP. That is called as the classical HSP. But what we see in adult rheumatology practice, 10% occur in the age of 20 to 40 years. 10% occur in the age of 20 to 40 years. Males more than female. That is called as adult onset HSP. Adult onset HSP. Right? So what is important? Henox-Lon purpura is a very important pediatric topic. Majority of the time pediatric class also will cover this topic. But we are telling you what is the rheumatology point here. Okay, rheumatology point we are trying to discuss. So what is the pathology? Pathology. Henox-Lon purpura. Recall the first slide today. First slide today we understood. It is an immune complex mediated vasculitis. Immune complex mediated vasculitis. Predominantly affecting capillaries on the skin. Small vessel. It is a small vessel vasculitis. It is a small vessel vasculitis. So predominantly affecting capillaries on the skin. Predominantly affect the capillaries on the skin, right? So post-infective, majority cases are post-infective. So this immune complex is activated by a infection, most commonly preceded by upper respiratory tract infection. Okay, post-infective, most commonly preceded by upper respiratory tract infection, and that is why it can mimic IgA nephropathy. Henox-Lon purpura can mimic IgA nephropathy. Okay, I am going slow, step by step, same proforma. We are at end of rheumatology. When I teach cardiology, please be prepared. This is the same proforma that we have to continue. Okay. So Henox-Lon purpura, 90% in children, 10% in adult. It is an immune complex mediated disease affecting small vessel, especially capillaries on the skin. Majority cases are post-infective, most commonly preceded by upper respiratory tract infection. That is why it mimics IgA nephropathy, right? So tell me, what is the clinical tetrad? What is the clinical tetrad? We want to know. What is the clinical tetrad? We want to know. So what are the four typical manifestations of HSP? Four typical manifestations of HSP we want to learn along with the pathology, reason for the manifestation, right? First one, 90%. IgA nephropathy mimic. Read, I'm coming to that point. I'm coming to all that point. So clinical triad, 90% of the cases present with palpable purpura. 90% of the cases present with palpable purpura, which is seen over the lower limb and the buttock. Which is seen over the lower limb and the buttocks. And what is the reason? It is due to the capillary involvement. It is due to the capillary involvement. So most common presenting feature of HSP is a skin rash. Palpable purpura over the lower limb and buttock due to capillary involvement. Arthralgia can also occur due to pathology. Immune complex, no? So it can cause to joint pain due to pathology. Patient can come with arthralgia due to pathology. Due to pathology. Abdominal pain and melena can also occur due to mucous membrane involvement of the GI tract. Abdominal pain and melena can occur because the capillaries in the mucous membrane of the gastrointestinal tract can be affected. Capillaries in the mucous membrane of the gastrointestinal tract can be affected, leading to abdominal pain and melena. है ना. कंसिडरिंग ऑल ऑफ यू आर वेरी हंग्री, आज का फीडबैक खाने के बाद देना, है ना. हंग्री स्टमक में फीडबैक मत लिखना, है ना. इट कैन बी वेरी टॉक्सिक. लास्ट क्लास नहीं है आज, कल एक और दिन बचा है ना. रूमेटोलॉजी 1 मोर डे इज लेफ्ट. चलो लेट्स कंटिन्यू. लास्ट मैनिफेस्टेशन 10 to 30%. 10 to 30% present with gross hematuria. 10 to 30% present with gross hematuria. And gross hematuria is due to IgA deposits on the glomerular basement membrane. IgA deposit due to the glomerular basement membrane. Patient can present with hematuria. Right? So never occurs without the skin rash. That is the way to differentiate. So in nephrology, you will learn the topic IgA nephropathy. IgA nephropathy, the differential can be henoxylon purpura. But IgA nephropathy is only kidney. Henoxylon purpura is multi-organ rheumatology. So skin rash is always there when we talk about the henoxylon purpura. Okay. So this is what is our point. So clinical trial. What is next? Diagnosis. Diagnosis is done by the skin biopsy and the treatment is reassurance only. So the diagnosis is skin biopsy. Treatment is reassurance only. Okay, reassurance only is there. Okay, because majority disease are self-limiting. Okay, so it is a good prognosis. There is nothing to worry. Most patients of henoxylon purpura recover without any treatment. Right? So this is how we want to remember. This is our second last topic. Henoxylon purpura, ANCA negative. Diagnosis is by skin biopsy. I have written there. Skin biopsy. So to complete our vasculitis syndrome, last topic of the day, Behçet's disease. Behçet's disease is also an example of mucocutaneous syndrome. It is an example of mucocutaneous syndrome. It affects 30 to 50 years. Males equal to female, but more severe in the males. Okay, more severe in the males. Okay, so very simple. Last topic hai na? So the continuity should not be lost. Tomorrow is just, we have got myositis syndrome, overlap syndrome. So just give me 5 minutes and we are done. 30 to 50 years, males equal to female, but the disease is severe in the males. It is severe in the males. Genetic risk factor. genetic risk factor is HLA-B5, HLA-B51, HLA-B51. Okay, genetic risk factor HLA-B51. This is the genetic risk factor associated with risk of Behçet's disease. What are the clinical manifestations? Simple table. What are the clinical manifestations? So major manifestation. Majorly, Behçet's is known for the recurrent painful oral aphthous ulcers. Behçet's is known for the recurrent painful oral aphthous ulcers. है ना? So there is not much to understand here. These are all facts, है ना? और जो नहीं समझ में आता ना वो लिखना, वो पोस्ट करेंगे. We will explain to you. Don't worry. Okay. So it is not like that. See, I understand. What we are right now is in a very unprecedented situation. Okay. So I know how tired you must be. I always empathize with all you students, but trust me, it's not that I'm having fun. So I'll be joining COVID duty from Monday. Okay. So I'm also going to be in the heart of the situation. Bombay situation is definitely getting worse. So we all have our things to look for. So don't give up, right? We have to push ourselves. This is not the normal time. So request again, just last one. Let's focus. Okay. Learn, complete the vasculitis and go. So major manifestation, recurrent painful oral aphthous ulcers. Recurrent painful oral aphthous ulcers. This is also the essential criteria. So for diagnosis of the disease, we have to have this manifestation. For diagnosis of the disease, we have to have this essential criteria. Along with that, let us look at the minor manifestations. One by one. Minor manifestations. So one, superficial thrombophlebitis. Okay, superficial thrombophlebitis. Minor manifestation number 2, erythema nodosum. Erythema nodosum is the second minor manifestation. Number 3, painful genital ulcers. It is the painful genital ulcers. We have bilateral hypopyon formation. There is the bilateral hypopyon formation, which is the dreaded manifestation. Please remember, the first disease we discussed today, giant cell arteritis, can also cause blindness. Last disease of the day, Behçet's, also can cause blindness, but the mechanism is different. In GCA, blindness was due to ischemia. Here it is due to hypopyon formation, bilateral hypopyon formation. And number 5 is the Petherji test. Petherji test, it is a sign of T cell hyperactivity. Petherji test is a sign of T cell hyperactivity. So what is the test? You have to give a skin prick more than 5 millimeter deep using, of course, sterile needle. Contaminated mat prick karna. So skin prick using a sterile needle. When you give more than 5 millimeter deep, it can cause induration. That is called as Petherji test positive. So to diagnose the disease, Behçet's disease कब सोचेंगे? when the patient has recurrent oral ulcer. That time you should suspect Behçet disease. We all know the common cause of oral ulcer is B complex deficiency. But even after giving B complex, if the patient is getting recurrent problem, please consider diagnosis of Behçet's disease. For Behçet's syndrome, you want diagnosis a clinical criteria. The diagnosis is a clinical criteria. So essential criteria plus 2 minor criteria. Essential with the 2 minor criteria can confirm the diagnosis. Essential criteria with the 2 minor criteria can confirm the diagnosis. So there has to be oral ulcer with any 2 of the minor manifestation. You can confirm the disease. You can confirm the disease, right? The treatment is steroids. The treatment is steroids. Because again, what is the reason to give steroid? It is not for the ulcer. It is to prevent the dangerous complication, that is blindness. It is to prevent the dangerous complication, that is to prevent blindness. So early treatment associated with good prognosis. Early treatment is associated with good prognosis. Okay. So जब तक लिख रहे हो pathergy test, you take a sterile needle and you give a prick on the skin, on the forearm, on the finger. You give a prick, preferably forearm, more than 5 millimeter deep. After 72 hours, you will see an induration. It is like Mantoux test. But here you don't give anything. You prick only using sterile needle. You get an induration that is called as pathergy test positive. Pathergy test positive. Once you confirm the disease, give the steroids, because steroids have got good prognosis and you can prevent the dreaded manifestation. You can prevent the dreaded manifestation, making the prognosis good. Making the prognosis good. Right? So this is what we have here. Okay? Yeah, bas nahi re, ho gaya. है ना? That is the end of the class today. Everybody can run away. Good night. Okay? Have sumptuous dinner. Enjoy the rest of the evening. है ना? Evening तो बचा नहीं, but फिर भी enjoy करिए. Yes. So run away. Anybody who has got anybody has got any specific slides to show, I will show you. Okay. What will happen? In normal people, nothing will happen. Nothing will happen after pricking. After pricking with sterile needle, it will heal normally without induration. Okay. Yes. So tomorrow we have got last class of rheumatology. We will be discussing myositis syndrome. We will be discussing overlap syndromes, and we will be completing with acute rheumatic fever. So that will be our initiation into the future cardiology class. Okay. We will be covering the topic acute rheumatic fever also, which is part of rheumatology, right? So Wegener, Church-Strass. Okay. One time I will just go back. You tell me about the slides first. Behçet's disease slide in front of you. Yes, one by one. I will keep telling you one by one. Let me show you. Yes. Okay. Takayasu's slide noted. I will show you Takayasu's slide. Okay. Behçet's slide, everybody. Okay. First slide, Behçet's done. Okay. Behçet's. Yeah. Good night everybody. Run away. Tomorrow we'll meet for one last time for rheumatology, then later. Right. Behçet's disease. First slide. Done. I will put up these slides. Don't worry. Behçet's ये सब जो है ना handwritten notes. These slides I'll put up on the club today. Don't worry. Yeah, I'll put it up on the club. राइट, पीछे चलते हैं, टाकायासु स्लाइड। I'll show you GCA also, don't worry. Okay, nephrology Dr. Vivek Goyal is teaching. Okay, so you will enjoy all the lectures very much, don't worry. Nephrology Dr. Vivek Goyal will be teaching. Dr. Vivek Goyal will be teaching nephrology, right? So he is DM Nephro. You will enjoy his class. It's wonderful. Right. Manifestation. Okay, Wegener's Chuck's. Okay, let me finish GCA last slide before we go ahead. See, Doppler in GCA, Doppler studies can check whether the artery is inflamed. Superficial temporal is superficial. So you can apply the ultrasound probe, do the Doppler, and see whether the flow is normal or not. So that can tell you whether the artery is inflamed and the lumen is narrowed or not. That you can check. The Pan Bechet's, the handwritten slides, I will post it on the club. Don't worry. I'm going to do it right away. Ocular in Wegener. Ocular in Wegener, I said ocular involvement in Wegener's is not common. But when it is affected, the most common ocular manifestation is panuveitis. Most common ocular manifestation in Wegener is panuveitis. Okay, Dinesh Kumar, that's your doubt. Ocular manifestation. This is the first slide of the day. This is the first slide of the day. What is asterisk in Bechet's? देखेंगे यार, है ना? Let's see. Just some importance, just to understand. These are nothing else. Whatever we have understood, that's all. Anything specific you ask, na? See, you will learn about the correlation. है ना? व्यास, किनल, हितेश व्यास, you are repeatedly asking pathology question. After infection there is activation of the system, immunoglobulin, IgA type response comes. So IgA type gets deposited in the skin, deposited in the GBM, that leads to the symptoms. That is a pathology correlation. IgA nephropathy mimics IgA nephropathy is what I have written. Most common manifestation in Wegener is chronic sinusitis. Most common manifestation in Wegener is chronic sinusitis. I told you within the ocular. Within the ocular, most common is panuveitis. Yes, I am coming there to the difference between the two. Soumya, please Google what is induration. You will get the picture better. Visual understanding you do. Induration you will see what happens in Mantuk's test, how to read. What is induration? Google it and you will understand better. Hmm? Yes, immunosuppression everywhere, that's a common concept. You start with steroid. Immunosuppression means steroids. Okay, drug of choice in PAN, steroids. Yes, Santosh, right? Chalo. Okay, chalo. So good night. Whatever doubts are there, you post later. Okay, chaliye. Pan uveitis means all layers are affected. No problem. Ask questions. That's not the problem. Chalo. Okay.